Firstly, we will be learning anatomy of tricuspid valve, which is a right atrioventricular valve complex made up of three things: three valve leaflets, annulus, supporting chordae tendineae, along with papillary muscles. It has three leaflets: anterior, septal, and posterior leaflet. The anterior leaflet is anatomically most constant echo feature, with septal and posterior leaflets being variable in size and position. The normal thickness being less than 3 mm with valve area of 4 to 6 square centimeters. Location of tricuspid valve is most rightward placed directly beneath the sternal edge and requires ultrasound beam to be angled sharply rightwards while maintaining the transducer contact with the chest wall. It is the most complex valve of all the four cardiac valves. The three tricuspid leaflets are attached around the tricuspid annulus, which has more variable geometry that does relatively circular mitral wall annulus structure. Anterior or lateral leaflet typically being substantially larger than the septal and posterior leaflet. Septal is the smallest of all the three leaflets and inserts in more apical position compared with the anterior leaflet. During diastole, the anterior and posterior leaflet have a sail-like movement and they meet to join the smaller septal leaflet. So, as discussed, the subvalvular apparatus also consists of three papillary muscles, the anterior, posterior and septal papillary muscles with their true chordae tendineae. The false chordae connects either the two papillary muscles or the papillary muscle to the ventricular wall or connect points on the ventricular wall. The true chordae typically originates from apical third of the papillary muscle but can originate from ventricular valve as well, as in case for septal leaflet. The anterior papillary muscle is the largest of all and the septal is the smallest. Because of the variable size of the three leaflets, it is difficult to ascertain the independent location, size and motion of any tricuspid leaflet. As shown in the picture, this is nomenclature for major cardiac valves. The most anterior is the pulmonic valve. It has three leaflets, anterior, left and right. And the most rightward is the tricuspid leaflet having septal, anterior and posterior leaflet as shown in the figure. For echocardiographic assessment of tricuspid valve, it can be visualized in multiple transthoracic and transesophageal imaging planes. From parasternal position, the tricuspid valve is well visualized in RV inflow tract view. It is obtained by medial angulation of the transducer such that the ultrasound beam is directed beneath the sternum. In this view, the right atrium, the right ventricle, coronary sinus and occasionally IVC with its eustachian valve are clearly visualized, and the two leaflets which can be seen in RV inflow view is posterior and anterior leaflet of the tricuspid valve. The second view to visualize tricuspid valve is modified parasternal short axis view, and in this view tricuspid valve is seen as 9 o'clock position as compared to aorta. And in this view, two leaflets, septal and anterior, are visualized. As shown in the diagram, first A image is parasternal long axis RV inflow view showing two leaflets, anterior and posterior, while the second image B is modified short axis showing septal and anterior leaflet at 9 o'clock position. The video demonstrating the RV inflow view as shown. The two leaflets can be seen moving of tricuspid valve, the anterior and posterior leaflet as shown in the video. And RA, RV and opening of IVC into RA can be seen in this video. This is modified parasternal short axis view demonstrating the two tricuspid leaflet, that is septal and anterior leaflet, along with RA, LA, RVOT and aorta as labeled in the diagram. The apical four-chamber view for tricuspid valve. From apical four-chamber view, the septal and the anterior leaflet of tricuspid valve are clearly visualized. Because tricuspid valve is both complex in anatomy and motion, AM mode echo plays a very little role in identification of any tricuspid valve pathology. When employed, it can demonstrate a two-phase opening pattern of the tricuspid valve similar to mitral valve. This is a apical 4-chamber view demonstrating septal leaflet and the anterior leaflet of the tricuspid valve. For transesophageal echocardiography of tricuspid valve, using TEE, tricuspid valve can be imaged in multiple imaging planes. The incremental yield of TE over TT is often less for the tricuspid valve being the most rightward structure. Valve can be visualized in 4-chamber equivalent view from behind the LA, in which case its appearance is similar to noted in TTE 4-chamber apical view. Also well visualized at the base of the heart in 80 to 110 omni angle. From a mid-esophageal transducer position, a short axis view of tricuspid valve can also be obtained. The transgastric view, the deeper gastric view in a longitudinal vein, provides a good visualization of tricuspid valve, as we will be seeing in subsequent images. The 4 views which we have discussed is mid-esophageal 4-chamber view from omni angle 0 to 90 degree, the RV inflow-outflow view, modified bicaval view, and the transgastric view. This is the mid-esophageal apical 4-chamber view at 0 degree omni angle as shown. The septal and the anterior leaflets of the tricuspid valve can be seen in the image as noted. It is similar to transthoracic apical 4-chamber view. This is at omni angle 120 degree with deep transgastric probe position. The apex of the RV, tricuspid valve, and RA are clearly visualized, giving excellent visualization of the tricuspid wall and the subvalvular apparatus like chordae and papillary muscle. And this is recorded at 110 degrees at the base of the heart. In this view, RA, RV, and SVC can be seen as demonstrated. And this is modified bicaval view showing LA, RA, interatrial septum, SVC and IVC draining into RA, and tricuspid valve between RA and RV. Doppler assessment of tricuspid valve. Because the effective orifice area of the tricuspid valve is greater than the mitral valve, the inflow velocities are lower as compared to mitral valve at any given flow volume. The mitral valve normal pattern consists of relatively higher inflow E wave and a lower velocity atrial systole A wave. In absence of significant pathology, tricuspid valve E by A typically exceeds more than 1, but the absolute value is lower as compared to the mitral valve as shown in the Doppler image. So after understanding the echocardiography for tricuspid valve, we will understand what all etiologies can affect tricuspid valve. As shown in the following diagram: rheumatic heart disease, carcinoid, various tumors, congenital pulmonic stenosis, infective endocarditis of tricuspid valve, Epstein's anomalies, EMF, valve prolapse, traumatic injury, RV infarction, papillary muscle dysfunction, secondary TR due to pulmonary hypertension, left to right shunt like atrial septal defect causing dilatation and TR, RV cardiomyopathy, and pacemaker related. So first, dealing with the first pathology, that is tricuspid stenosis, it is infrequently encountered. Most common cause being rheumatic heart disease, in which case MS will be invariably present. Other etiologies which can cause tricuspid stenosis are carcinoid, RA myxoma, infective endocarditis, and congenital tricuspid atresia. Echocardiography definition of severe tricuspid stenosis is mean gradient more than 5 mm of Hg with pressure half time of more than 190 milliseconds and valve area less than 1 centimeter square. How do we calculate tricuspid valve area? From PHT is 190 divided by PHT. But to remember, in mitral valve area calculation, the numerator will be 220 divided by PHT. Other findings which are present in tricuspid stenosis are dilated RA, dilated IVC, and the doming tricuspid valve. As shown in the diagram, apical 4-chamber view, it is recorded in case of rheumatic heart disease. In mid-diastolic view, note the doming pattern of the tricuspid valve as shown by the arrow. The upper left view is the detailed Doppler recorded in the mid diastole from the tricuspid wall, showing the relatively constrained diastolic orifice. The upper right is the Doppler flow demonstrating mean gradient of more than 5, showing severe tricuspid valve stenosis in a case of rheumatic heart disease. For tricuspid regurgitation, unlike TS, TR is much more common, most common etiology being functional, that is secondary TR. While primary disease of tricuspid valve causing primary TR can be infective endocarditis, trauma, myxomatous valve, or the post-PPI status. The severity of functional TR is related to the degree of apical tethering of the tricuspid leaflet, which is quantified by tethering area or the height, which in subsequent figures we will be seeing, which in addition to providing the mechanistic insight may predict success of tricuspid valve repair. Echocardiographic grading of tricuspid regurgitation severity includes the parameters like tricuspid valve. In severe, there will be abnormal flared leaflets with very poor coaptation. In severe TR, RA, RV and IVC will be dilated. The jet area, central jet will be more than 10 cm square with vena contracta of more than 7 mm and pisa radius of more than 0.9 cm. The jet will be dense triangular with early peaking with hepatic veins showing systolic reversal. As shown in the diagram, apical 4-chamber view emphasizing the tricuspid valve in secondary TR, which is the functional TR. Note, as you can see, there is apical displacement of both the belly and the coaptation of the tricuspid valve leaflet. The tenting area, which can be calculated as the area defined by the plane of the tricuspid annulus, showed by the dashed line, and the apically displaced leaflet and shaded area. In the color flow, you can note the severity of TR originating from the tenting area. We can calculate RV systolic pressure and thus PA pressures by using Bernoulli's equation, which is defined by RVSP is 4 velocity square plus pressure of RA. And how will you define the pressure of RA? It can be 5, 10, 15 depending on RA size, TR severity, TR Vmax and IVC. With severe will be when RA size is increased, with severe TR with TR Vmax of more than 4 and IVC being dilated with no respiratory variation. This is transthoracic echo recorded in RV inflow view. As demonstrated, the figure is demonstrating the large destructive vegetation on the tricuspid valve leaflet in the upper panel, which has caused primary severe TR, as shown in the color Doppler view in the second image. The other pathology which we will be studying is endocardial fibroelastosis. It is marked inflammation in the endocardium, which can extend to the chordae, which will interfere with the normal valve coaptation. Leaflet will appear to be restricted and bound towards the ventricular valve. It is often associated with obliteration of RV apex due to inflammatory tissue and secondary thrombosis. Epstein's anomaly is defined by apical displacement of the septal leaflet by more than 8 mm per meter square of body surface area, as well as lateral leaflet tethering to the apical wall, as will be seen in apical 4-chamber view in subsequent image, resulting in the coaptation of tricuspid leaflet in a position displaced towards the RV apex, thus creating a atrialized portion of the RV. It will have dilated RV with visualization of tricuspid valve tissue in what would have been anticipated to be RV outflow tract. If actual leaflet coaptation cannot be identified, colored Doppler will demonstrate TR to be originating from a apical displaced conversion zone, which provides a clue to us. As shown in the image, that is apical 4-chamber view, you can see apically displaced septal leaflet with lateral tethering, with the second image showing TR originating from apically displaced area. In parasternal long axis view, we can see the Epstein's anomaly of tricuspid leaflet. You have to know the arrow demonstrating the tricuspid valve leaflet is visualized as RV outflow tract. This is related to the apically displaced tricuspid valve within the RV. Now moving on to the anatomy of pulmonary valve. It is a three-cusp structure. It inserts in the pulmonary annulus distals to IRVOT. When viewed with the 2D echo, typically only one or two cusps are simultaneously visualized. Specialized image may allow visualization of pulmonary valve in its short axis. However, it being relatively thin and highly pliable, leaflets are often not visualized in its entirety. As shown here, the pulmonary wall is the most anterior valve and it has three cusps named as anterior, right and left leaflet. For echocardiographic assessment of pulmonary valve, transthoracic echo first begin with modified short axis view at the level of aortic valve, while pulmonary valve anatomy can be examined for thickening, doming or any vegetation. Although apical and subcostal views can be useful in imaging RV as it relates to the pulmonary artery and the pulmonary valve, it is often difficult to adequately image the entire pulmonary artery system in these views. As shown, this is modified short axis view demonstrating the RVOT, the pulmonary valve and the pulmonary artery, the main pulmonary artery, which further bifurcates into right and left pulmonary artery. This is parasternal long axis view of the demonstrating RVOT, pulmonary artery and the pulmonary valve recorded in diastole. This is the subcostal modified short axis view of the base of the heart, shows a portion of the right atrium, tricuspid valve, right ventricle and the outflow tract, pulmonary valve and pulmonary artery. Structures are as noted in the schematically in upper left of the figure. Transesophageal images of pulmonary valve. It can be visualized in various views. The first view includes imaging at the level of the aorta in an omniplane of 40 to 60 degree and in horizontal 0 degree plane at a relatively shallower depth, typically 25 centimeters from the incisors, for which we have to do counterclockwise rotation of the probe. In this view, we can visualize bifurcation of pulmonary artery, which will be shown in the subsequent figures, and pulmonary valve can likewise be visualized. The third view is deep transgastric view. For this, we have to do clockwise rotation of the transducer, and the entire sweep of RV inflow outflow can be visualized with simultaneous visualization of right atrium, tricuspid valve, RVOT, pulmonary valve and proximal pulmonary artery. The first image, this is transesophageal images recorded at first A is recorded at omniplane of 55 degree angle. It demonstrates RVOT and the pulmonary artery and the pulmonary valve, which can be clearly visualized. The B image is the pulmonary valve and the larger portion of the main pulmonary artery with RPA at omni angle of 0 degree. The M mode echo for pulmonary valve. From parasternal approach, motion of the pulmonary valve can be visualized. Typically, M mode will intersect only one leaflet by its beam. There are several components to normal pulmonary valve motion. The first is the presystolic A wave motion away from the transducer, which is due to low amplitude excursion of the pulmonary valve due to atrial systole. This phenomenon depends on following things. Firstly, the mechanical atrial systole, and it also depends on the relatively low pulmonary artery diastolic pressure, so that the atrial contraction can create a driving force for the opening of pulmonary valve, which we will see in following images. This is demonstration of modified short axis view at the base of the heart. The probe is directed towards the pulmonary valve and the M mode echo is done cutting the pulmonary valve. The first image we can see is the normal pulmonary valve, which has two waves. The first wave is the presystolic A wave due to RA contraction, and second is due to RV contraction. If there is infundibular obstruction, there will be the fluttering of the second wave as shown. If there is pulmonic stenosis in the third image, note the A wave is accentuated. The fourth image is idiopathic dilatation of pulmonary artery, which will show fine coursing of the second wave. The fifth image is the pulmonary hypertension image of M mode. Note here, due to raised PA pressure, the pulmonary valve won't open due to RA contraction. Thus, there is no A wave in this. There is notching in the second wave. This is the images, M mode images real time, as shown in the following figures A, B, C, D, as I have explained in the previous slide. The Doppler echocardiography assessment of the pulmonary valve. Normal pulmonary outflow velocity will range from 1 to 1.5 meter per second. We can calculate time velocity integral at this level, and after multiplying it with the RVOT diameter by continuity equation, we can calculate stroke volume. Multiplying stroke volume with heart rate can provide with RV cardiac output. The second important thing is acceleration time. It is the time in milliseconds from onset of the ejection to the peak systole. Normally it is more than 140 milliseconds. And as there is progression of the pulmonary hypertension, this acceleration time will go on decreasing to the point when there is acceleration time of less than 70 milliseconds, it indicates severe pulmonary hypertension. We can calculate mean PA pressure by using formula of 79 minus 0.45 into PA acceleration time. As shown in the figure, we can calculate velocity time integral, multiply it by area, and thus we can calculate the stroke volume and the cardiac output. This is the summarized formulas, 5 formulas which we have to remember. Firstly, RV systolic pressure we can calculate by TRG max plus RA pressure. For PA systolic pressure, we have it is by RV systolic pressure plus the pressure gradient. For calculating PA diastolic pressure and mean PA pressure, we use pulmonary regurgitation jet. For pulmonary artery diastolic pressure, we use the end diastolic PR plus the RA pressure. And for mean pulmonary artery pressure, we calculate by peak PR pressure plus RA pressure, as will be demonstrated in further video. And Bernoulli's equation we all know, delta P is 4V square. The video demonstrating the pulmonary valve opening. A continuous wave Doppler is applied at the pulmonary valve opening. We can see there is PR jet. The jet has the primary for the first peak as shown. We will be calculating the mean PA pressure by this first jet, pulmonary artery and diastolic pressure. Now grading of pulmonary arterial hypertension divided into 4 grades. Grade 1, 2, 3, 4. Grade 1 when the systolic PA pressure is between 30 to 50. Grade 2 when it is 50 to 70. Grade 3 when it is 70 to 110. And grade 4 it is suprasystemic more than 110. The first pathology which we will be dealing is pulmonary valve stenosis. It is virtually always congenital. It is thickening and systolic doming of the pulmonary valve cusp. What are the findings on 2D echo? It will be RV hypertrophy, systolic valve doming, valve thickening, and post-stenotic dilatation of mean pulmonary artery. The CW Doppler will demonstrate peak flow velocity across the wall and is measured and converted to peak PA pressure by Bernoulli's equation. Definition of severe PS will be peak velocity more than 4 with mean gradient more than 40. And M mode will demonstrate exaggerated A wave during diastole, as we have discussed previously. This is the short axis modified view in patients with congenital PS. The second image demonstrates the Doppler with mean PA pressure of around 4.5, which indicates severe PS with peak gradient of around 81 mm of Hg. The color Doppler images depicts eccentric acceleration towards the stenotic orifice as well as eccentric jet in the pulmonary artery. This is the transesophageal view recorded in adolescent stage. with congenital pulmonary valve stenosis. The image was recorded in mid-systole. Note that thickening of the pulmonary valve leaflet and the doming motion arrows characteristic of the valvular pulmonary stenosis. Now moving on to pulmonary valve regurgitation. Causes include, the most common cause is dilatation of pulmonary valve annulus, that is secondary PR. It can be idiopathic as well as due to pulmonary arterial hypertension, or it can be due to congenital absence of one or more pulmonary valve cusp, infective endocarditis, and carcinoid disease. On 2D echo, you look for thickening, presence of infective endocarditis vegetation or other vegetation, prolapse. Color Doppler examination of antegrade and retrograde flow in short axis view across the pulmonary valve with visualization of both RVOT and proximal pulmonary artery gives the most information about PR. We calculate vena contracta, volume of RVOTO occupied with the regurgitation jet, and percentage of time in diastole occupied with the regurgitation. Severe will have a dense jet with rapid deceleration so that the flow ends in mid diastole, while mild to moderate will persist throughout the diastole. Pressure half time less than 100 with a jet length of more than 10 mm, which is 1 centimeter, will determine severe PR. Severe PR will also have RVOT dilatation, RV and RA dilatation. Velocity of flow is not proportional to severity of regurgitation and should not be used for classifying pulmonary regurgitation severity. Indirect markers will be RV dilatation and RV volume overload pattern. As shown in the images, first is mild PR, second is moderate PR, and third is severe PR, demonstrating length of PR jet more than 10 mm. Thank you so much.